Welcome to Hersing University NU 640 Introduction to Women's Health Across the Lifespan. This video will discuss Chapter 30 from your Alexander and Colleagues textbook, as well as Chapter 22 from your Sarkio and Sikor text. This discussion will serve as a brief overview of the material. Therefore, I would like to ask that you please read the chapter for additional and required information. Additionally, I would like for you to review all other required and supplemental resources. This presentation will be represented by myself and Dr. Alicia Sutton.
Next, I'd like to discuss syphilis, which is an ulcerative genital infection. It is a systemic disease characterized by periods of active symptoms and periods of symptomless latency. It is transmitted by direct contact with an infectious moist lesion. In the majority of cases, it is sexually acquired, although it can be vertically transmitted from mother to fetus. Syphilis is a complex infection that can lead to serious systemic disease and even death when left untreated. You will always want to screen for this if a patient is positive for HIV, or in men who have sex with men, any presence of genital ulcers, previous STDs, pregnancy, IV drug use, or any other high-risk behavior. Infection will manifest itself in distinct stages with different symptoms and clinical manifestations. The signs and symptoms are dependent on the stage of the infection. So in primary, the patient will have a painless chancre, which will heal in 6 to 9 weeks if not treated. The chancre has a clean base with well demarcated and indurated margins. In secondary, the patient develops condyloma latae, which is infectious white papules in moist areas that look like white warts. They will also have a maculopapular rash on the palms and soles that is non-pruritic. In the latent stage, the patient will be asymptomatic, but will have positive titers. In the tertiary stage, the patient will have neurosyphilis, valvular damage, aneurysms, and soft tissue tumors called gummas. So I want to add this unusual complication of treatment. The Jarisch-Herxheimer reaction is an acute febrile reaction frequently accompanied by headache, myalgia, fever, and other symptoms that can occur within the first 24 hours after the initiation of any therapy for syphilis. Patients should be informed about this possible adverse reaction and how to manage it if it occurs. You will also want to be aware of the diagnostic tests for syphilis. So the screening test is the RPR or VDRL, and the diagnostic test is the fluorescent antibody absorption antibody, or better known as FTA-ABS. To break it down even more, if the RPR or VDRL is positive, then you will do the FTA-ABS. If both are positive, then you have a confirmed diagnosis of syphilis. Lastly, recheck the RPR or VDRL at 6 months and 12 months to monitor treatment response. Now, the treatment's going to vary depending on the stage of the disease, so I want you to know that high-dose injectable penicillin is preferred. I'd also like to include treatment during pregnancy. Parenteral penicillin G is the only therapy with documented efficacy for syphilis during pregnancy. Pregnant women with syphilis in any stage who report penicillin allergy should be desensitized and treated with penicillin. In terms of genital herpes, it's important to know that herpes simplex virus type 1 and 2 can cause genital lesions. They are painful genital ulcers that have been described as feeling like a canker sore. This is a chronic, lifelong, relapsing condition that can be transmitted even if there are no lesions present. It's also important to know that a woman can be exposed 20 years prior to her first breakout. In other words, the virus can lay dormant for many years. So typically we will not do antibody typing to determine what type of virus it is. However, if a patient presents with a lesion, we will want to do a viral culture to confirm. Now, we have been trained in respect to primary outbreaks and that they're usually very uncomfortable and painful for a patient. But I want you to know that there are patients that have primary outbreaks that do not present with classic findings. Typically, though, a patient will have a prodrome of itching, burning, and tingling, then a sudden onset of group of small vesicles sitting on an erythematous base. These vesicles easily erupt and are painful. The primary episode can last 2 to 4 weeks. And the vesicle fluid and crust are contagious, so you must educate your patient. Treatment, of course, is the acyclovir antivirals and is going to be the primary regimen for this in combination with comfort measures. All patients with first episodes of genital herpes should receive antiviral therapy, which would be acyclovir 400 milligrams by mouth 3 times a day for 7 to 10 days. You can also use valcyclovir and famciclovir, which is both suitable, and then extend the treatment if healing is not occurring as expected. Now I want to stop and speak a bit about reoccurrence. And as you are aware, your patients may have recurrences, so you want to be sure to educate your patient on this. You will want to give some antiviral meds to have on hand for that. And if she is having a lot of outbreaks, you may need to consider prophylactic treatment. And suppressive acyclovir treatment late in pregnancy reduces the frequency of C-section deliveries among women who have recurrent genital herpes by diminishing the frequency of recurrences at term. However, such treatment may not protect against transmission to the baby in every case. Even though a chancroid is very uncommon in the United States, I would like to take a moment to briefly discuss the infection. I would like for you to make note that a chancroid is a genital ulcer and it is a risk factor for HIV transmission. The major way chancroid is acquired is through sexual contact and trauma. Typically, your patient will present with a history of a painful macule on the external genitalia that rapidly changes to a pustule and then an ulcerated lesion. You may note an enlarged unilateral or bilateral inguinal nodes. After 1 to 2 weeks, the skin overlying the lymph node becomes erythematous and the center necroses and the node becomes ulcerated. The recommended treatment for chancroid includes azithromycin, 1 gram orally in a single dose, or ceftriaxone 250 milligrams IM single dose, or Cipro 500 milligrams orally twice a day for 3 days, or erythromycin 500 milligrams orally TID for 7 days. And the last topic that I would like to discuss with you in this portion of the lecture is expedited partner therapy. So EPT, also termed patient-delivered partner therapy, is the clinical practice of treating the sexual partners of persons who receive chlamydia or gonorrhea diagnoses by providing medications or prescriptions to the patient. Patients then provide partners with these therapies without the healthcare provider having examined the partner. Medications that are given should be accompanied by treatment instructions, appropriate warnings about taking medications, such as if the partner is pregnant or has an allergy to the medication, general health counseling, and a statement advising that partners seek medical attention for any new or worsening symptoms. Please read more on this topic on page 8 and 9 of the CDC guideline.